Hi everyone. I want to welcome you guys to Medgotol, a global channel whereby we're discussing medicine. We started USMLE series. Yesterday we started cell deaths, and then we spoke about two major ways a cell can die, either by necrosis or by apoptosis. And we started talking about necrosis. And under necrosis, we start talking about different types of necrosis based on the gross appearance. And the first one we spoke about yesterday was coagulative necrosis. And just a quick recap for coagulative necrosis, we mentioned that this is a type of necrosis whereby the architecture or the structural outline of the cell is preserved. And we said that it could either be due to maybe because of hypoxia, causing elevated lactic acid, right? Or because of heavy metal or ionizing radiation. And we said any of these, right, could lead to could denature the protein. And if the proteins are denatured, right, maybe the structural protein. So as a result of that, right, the those structural protein that are responsible for the structure of the cell, they have to be dead, right? And then we say at the same time, the enzymes, for instance, the protease that's supposed to break down those dead cells, they also denature too, right? So they can't break down those dead cells. So as a result of that, we have this accumulation of this dead cell, right, inside the cell, which is what we call, which is where the name comes from, coagulative necrosis. And we said, thank God for neutrophil, right? By 12 hours to 24 hours, neutrophil will start moving in, causing inflammation in those cells. And then by day 3, macrophage will start to roll in, digging out those debris, taking them out, right? And of course, by the time we clear out those debris, we start putting in granulation tissue there, starting that process of repair, right? And that's coagulative necrosis. And then today, I'm going to focus on the progression. I'm going to focus on the progression of gross and microscopic findings in acute myocardial infarction. So we're using acute myocardial infarction as an example of what we see, that progression that we see in coagulative necrosis. And the reason why I'm using acute myocardial infarction, right, which is the term that we use out there, which is heart attack, right? So the reason why I'm using that is because it's a commonly tested also question on the exam, and of course, it's one of the leading causes of death in this country. So let's look at progression of acute myocardial infarction. So MI is myocardial infarction. And I'm going to be talking in terms of gross changes and microscopic changes. So we're going to start with the first 24 hours. So the first 24 hours, so we're going to divide it into two. So on this side, we can put our gross. And of course, on this side, we put the microscopic findings. So first 4 hours. So in the first 24 hours, right? When you look at the gross, right, you should not see anything, right? So it should be no change. So you can see a question saying that a patient was like maybe like a 56 or 56-year-old male, right, with history of smoking history, right? So smoking history with hypertension diabetes, right? And a new onset chest pain, right? And of course, they could also add diaphoresis, right? So patient is diaphoresis. It feels like elephant is sitting on his chest, right? That's how those patients always present, right? So with this history, right, with this somebody who has significant history of arteriosclerosis disease, after the new onset chest pain, particularly left-sided chest pain, with diaphoresis, I'm thinking this could be a heart attack, right? So in the first, so if this patient presents in the first 24 hours, God forbid bad thing. Let's say this patient died, right? I will do autopsy on this patient. What are you going to see on the cross in the first 24 hours? Nothing, right? So there will be no changes, right? Because it's too early to start seeing stuff, right? But on that microscopic level, right? Because this is related to ischemia, right? Like we mentioned yesterday from previous lecture, right? The tissue is going to shift from aerobic to anaerobic glycolysis. And as a result of that, those pyruvate will be converted to lactic acid. And the lactic acid is going to start to denature the protein and the enzyme, right? It's going to denature those structural protein. It's going to denature the enzymes. And this will lead to coagulative what? Necrosis. So we can start seeing coagulative necrosis in this patient. Yes. So when you look under microscopy after 4 hours, right? So in 0 to 4 hours, you may not see anything on the microscope, right? But after 4 hours, you should start to see some form of what? Necrosis, right? And that's when the cardiac enzymes start to go up. So that's why if somebody is having heart attack, at the initial stage, right, within the first few hours, like 1 to 3 hours, right, you may not see any cardiac enzyme because at that point we don't have like a full-blown necrosis at that time, right? That's why we do serial cardiac enzyme, right? To keep checking it maybe every 6 hours. I'm checking for those rise, right? Because your first cardiac enzyme might be normal, but your subsequent one will start to go up. So that's why we do serial cardiac enzyme. So after 4 hours, we expect to start seeing some form of necrosis, right? And apart from that, after 12 hours, right, we start to see neutrophils start to moving, right? After 12 hours, right? Like we mentioned yesterday, right? After coagulative necrosis, then neutrophil needs to move in because the protease enzyme they are supposed to break down those dead tissues, they are inactivated, they can't break down the dead tissue. So we have to look for other ways of breaking it down, right? So neutrophils start to move in, right? And of course, like I mentioned, cardiac enzyme are released into the blood, right? Which is at that point, when we start seeing those cardiac enzymes going up, we can say, oh, right, this patient is having a heart attack, right? And of course, before now, you can see some EKG changes, which we have to talk about in details when we get to cardiovascular system, right? And the cardiac enzyme, particularly that we normally look for, right, troponin, and the other one is also creatine kinase, right? And the MB, which is the isotype that we're looking for, right? And then during this period, it's important to know the complication that will happen in this first 24 hours. So for instance, let's say I'm working in the emergency department, I got a call, a 56-year-old male, history of smoking, hypertension, diabetes, new onset chest pain, and they said we're preparing for them already. And then before the patient got to the hospital, the patient died, right? Most likely, right, the most common cause of death at this hour, right, with this time frame is usually arrhythmia, right? So very important. So arrhythmia, so complication at this time, arrhythmia is a big one, right? And particularly ventricular fibrillation, right? Ventricular fibrillation or ventricular tachycardia. So very important. We need to remember this, right? The other complication that will also occur, let's say this patient got to the hospital, but now this patient is now having, in addition to these symptoms, this patient is having shortness of breath, now having autopnea. So autopnea is when they lay down flat, they're having trouble breathing. So now having autopnea on examination, there's bilateral inspiratory crackles, right? right? Or there's jugular venous distension, right? So all this is pointing to me now that this heart attack that they're having has now progressed to what? To cardiac failure. So now they're having heart failure, right? Right? And then most of the time, once you fix the, if you are fast enough and you fix the heart attack, you open up the blood vessel, you can fix the heart failure could be fixed, right? Which is something that we need to bear in mind, right? And then the last thing, right, that we should also be aware of in this window period is that if this patient does not present on time, especially if they present after 12 hours, right, these patients, they are very high risk for reperfusion injury, or we call reperfusion injury, right? So the way I imagine reperfusion injury is that if you have all these cells, right, and then the blood vessel has been blocked for a while and the patient did not present on time, so all those systems in this cell that should be fighting against free radicals, they are not there anymore, right? They've been also been impaired by the ischemia, so they're also being affected. So or by the infarction. So as a result of that, right, if this patient comes in, right, and then you open up, so let's say the blood vessel was blocked and all this tissue, they start dying already, right? And then this patient presented after 12 hours that the chest pain started. So if you open up this blood vessel and blood and oxygen start going there, so blood will start moving oxygen to those tissue, right? So those oxygen can actually be converted to free radical. So you can start generating things like hydroxyl free radicals, right? And that can further damage those tissue, right? So that could further damage those tissue, and that's what we call reperfusion injury. And of course, calcium can influx into those cells, right? And it can cause severe like hypercontraction of those myofibrils, and that will also further impact this tissue. So the way you should imagine reperfusion injury is somebody that is having a heart attack, right? Presented, let's say we check, by the time they came in, we checked the troponin. Let's say, for instance, the troponin was elevated at, let's give it a value. Let's say it was maybe 5,000, right? So the cardiologist saw the patient, cardiologist took the patient for percutaneous coronary intervention, whereby they open up the blood vessel. And then after they open up the blood vessel, the troponin goes from 5,000 to 20,000. The only thing that will explain that is going to be reperfusion injury, right? Right? Because that was too quick, right? So most of the time, so you always think of that in this context, right? So if somebody who had obstructed coronary artery disease was opened up, and after the troponin went from 5,000 to 20,000, that tells me that this patient is undergoing reperfusion was injury. So something that we need to bear in mind for the exam, right? So that's the first 24 hours. So let's move on to the next one, which is going to be 1 to 3 days. So what are we going to see for the gross? So between day one and 3, right? When you look on that gross, right, those infarcted tissue is going to appear pale, right? Because there's no blood going there, so they have to appear pale, right? And then what about on microscope? What are we expect to see, right? So on the microscopic level, right, we're going to start seeing that there ought to be disappearance of the myocyte nuclei and striation. So when you look at them, just same thing that we mentioned for coagulative necrosis yesterday, that the nuclei, right, they will start to disappear. So disappearance, which is what we call chiriolysis, right? Myocyte nuclei, right? And of course, when you look at, because remember, cardiac muscle, they're also striated. So those striations will start to disappear too. And another thing we're going to also see within this period is that you're going to see extensive coagulative necrosis. So those areas that are being affected, you're going to see extensive coagulative necrosis in those areas. Necrosis. And by this time, neutrophil is heavily has heavily infiltrated the cell, right? So we're also going to see extensive neutrophil infiltration. And of course, with neutrophil, anywhere neutrophil is, right? Remember, like we mentioned yesterday, neutrophil is what? Is part of the acute inflammatory cell. It's a major acute inflammatory cell. So this also leads to acute inflammation. And this is very important for us to remember, right? Just like the scenario that we just posted, like our patient that presented history of smoking, diabetes, hypertension, came in with new onset chest pain, diagnosed the patient with myocardial infarction, right? Patient is admitted on day 3 or on day 2, patient start complaining of chest pain. And they say when they lean forward, the chest pain get better, right? So now on day 3 or day 2, right? So they start having new onset chest pain. And they said the chest pain is relieved by lean forward. So this is classic for what we call post-infarction fibrinoid pericarditis, right? So because when you look at the like the heart, right, it's covered by pericardium. So the pericardium is covering it, right? So let's say this area, this is where the dead tissue is, and there's a lot of neutrophil, right, causing inflammation in those areas. So those inflammatory cells now, they want to irritate the pericardium in that area, right? And as a result of that, that irritation will cause a chest pain. And then most of the time when they lean forward, that leads to separation of the pericardium from the myocardium. So there's going to be less irritation. And that's why the chest pain gets better, right? So that's classic post-infarction fibrinoid pericarditis, right? Normally, if it's like acute pericarditis from any other cause, right? What's going to be the treatment? So acute pericarditis from every other cause. So we normally use things like steroid, right? NSAID, right? Or cortisone. So any of these can be used for pericarditis from other causes, but we try not to use this in myocardial post-infarction fibrinoid pericarditis because of increased risk of rupture, right, or complication. So if this patient now, if you want to treat this patient, all you have to do is just increase the dose of their aspirin, right? So you can give them high dose aspirin, which is also what we use if somebody is having a heart attack, right? It's one of the medication that we use. So that's day 1 to 3. So moving on to the next one. So what happened in day 3 to day 14, right? So we cover days, day first 24 hours, then we cover 1 to 3 days. Now we're covering 3 to 14 days, right? So on gross, what are we expecting? So for gross, right? At that point, we're going to see, so initially, remember between day 1 and 3, it was a pale area, right? So now, because of the inflammation that is going on, right? There ought to now be blood flow, right? Increased blood flow to those area, around that area now because of the inflammation, right? And that will cause, we're going to start seeing what they call acaremia border. So the surrounding area to appear red, right? And of course, in the center of the necrosis, you're still going to see those yellow, brown in the center. And as time goes on, the other thing that will start appearing, right, when macrophages come and remove those debris, right, then we're going to see appearance of the granulation tissue, which is our beefy, which we normally describe like a beefy red appearance, right? So what about the microscopic finding? So with the microscopic finding, so one thing that is important by day 3 that we normally mention, right, Neutrophil has caused this inflammation. Now it is time for macrophage to move in. So macrophage is going to move in, and it's going to start removing the dead tissues, right? It's going to start removing those dead tissue, and after I start removing those dead tissue, once you clear out those dead tissue, then there ought to be appearance of the granulation tissue. So the granulation will start producing granulation tissue so that we can fill back those space that is being created by macrophage. So granulation tissue will start to appear. So one thing that is very important during this period, right? Imagine you have, so let's just draw a picture here, right? So let's just draw a picture of let's just assume this is let's assume this is the heart, right? And this is our chambers, right? So let's say somebody have maybe a big myocardial infarction that is involving this area, right? The anterior part of the septum, right? So if someone is having big myocardial infarction involving this area, let's just imagine the anterior part of the intravascular septum or the left ventricle, right? From blockage of maybe LAD, right? Left coronary artery. Left anterior descending artery, which is a branch of left coronary artery, which supply that area. So if there's a blockage of that, right? So just imagine macrophage coming in and then removing all those debris that neutrophil has done, right? So what happened? The tissue wants to be very soft. So at this point, the tissue is high risk for rupture. And this is where you have to pay attention to the days when they're printing the scenario, right? So for instance, let's say on day 5, that same patient on day 5, right? You come in the morning to come and examine the patient, or the nurse call you by the bedside saying that now the patient is having new onset shortness of breath. The patient doesn't look good. You go there, you examine the patient, right? You realize that the patient is hypotensive. Patient is tachycardic. The jugular venous distension, right? And in addition to that, there's a distant heart sound, right? Or sometimes we say muffled. So muffled heart sound means that you can't hear it very well, right? Anybody know what we call this triad? Hypotension, jugular venous distension, and distant heart sound. What do we call those triad? Very good. So that's what we call Beck's triad, right? Beck's triad. So this triad is classic for what? Cardiac tamponade. So what tells me now is that this patient probably, so let's say this is the pericardium, right? Basically what happened is that there's a free wall rupture, right? Because this is a 2D picture, so it's difficult to show what I'm trying to explain. Basically what happened is that the wall, the infected area, the muscle has ruptured. So all the blood that's supposed to be in the chamber, they start to escape into the what? Into the pericardium, right? So as a result of that, right, that could compress both the IVC and SVC, superior vena cava and inferior vena cava, impairing the blood return, right? So which can lead to hypotension. Because of a lot of blood inside the pericardium, right? That will also make the transmission of sound to be impaired, right? So they have to have, that's why they have to have distant heart sound or muffled heart sound. And then because the blood cannot come in because of the decrease in the venous return, right? What also happen as a result of that, they have to have jugular venous distension, right? So always think of cardiac tamponade. Of course, what to be the treatment? You have to drain it, right? So pericardial synthesis, right? So moving on, what about this same patient at day 5? Let's say you also go there, nurse call you that the patient is not looking very well, and when you went there, patient is hypotensive. Patient is hypotensive, and the patient is having significant shortness of breath. Patient is having autopnea, right? So autopnea, when they lay down, they're having trouble breathing, right? So you have to raise them up. And then when you examine the patient, and patient has holosystolic murmur at the mitral area, or sometimes they will say at the apex. So apex, right, is where we listen to mitral. And if you want to help it, they can say it radiates to the axilla. What do you guys think? Very good, mitral regurgitation. So this patient is having mitral regurgitation. So why mitral regurgitation at this time? So most likely it's going to be from the what? The papillary muscle rupture. So most likely that's what to happen, right? And of course, this patient might need they might need surgery to fix it. And there's some temporizing measure before surgery, which we want to talk about when we get to cardiovascular. So that's another complication that will happen. So those might the papillary muscle that is holding the mitral valve, if they rupture, that will lead to potential severe mitral regurgitation, right? Moving on, what about this same patient, same day, on day 5, same patient, the patient is hypotensive, they're having shortness of breath, they're having maybe autopnea, but this time around, this patient is having holosystolic murmur, right? But the holosystolic murmur is at the lower left sternal border. And then sometimes they can describe this type of holosystolic murmur as arch holosystolic murmur. What do you guys think? Very good, right? So you're thinking of VSD. So it looks like the murmur that we hear in VSD, ventral septal defect. So this is most likely due to intraventricular septum rupture. So as a result of that, right, that creates a left to right shunt of blood. So, and that creates that holosystolic murmur. And this patient also needs a surgery. So you can see it's kind of like similar to what we see with papillary muscle rupture. So we want to opt to differentiate both of them on the exam is the location. So if they are hearing that holosystolic murmur at the apex, right, which is the 5th intercostal space, right, in the mid clavicular line, right, on the left side, you know that most likely that's mitral papillary muscle rupture. But if it's at the left sternal border, right, you know that that's most likely that's intraventricular septum rupture, right? And of course, the last thing that will also occur, this patient will also develop what they call left ventricular pseudo aneurysm. Right? So basically, when you look at the muscle, so let's say this is the infarcted area. This is the area that's infarcted. So what happens is that there's going to be this like a pseudo aneurysm that is forming in that area. And because this is a very soft aneurysm, very thin wall aneurysm, there's high risk of rupture, so it can also rupture. So that's what we see in day 3 to day 14. So the most important thing is to remember the complication that could occur. That's when there's high risk for rupture. And don't forget, somebody just asked me, sometimes on the exam, they may not call it holosystolic, they may say pansystolic. Both of them means the same thing. Basically, it means a murmur that occurred throughout the systole, right? And then moving on to the last one, what about if it's more than 2 weeks or more than 14 days? So what are we going to see on gross? So at that time, right, granulation tissue has been laid, and then those granulation tissue now, they want to be replaced by the permanent collagen, right? By type 1 collagen, right? So by the time you look at it on gross, you're going to see those gray-white scar, right? From those collagen deposition, right? So that's what you're going to see on gross. And what about microscopy? So when you look under the microscopy, Same thing, we're going to see those contracted scar in those areas. So during this period, what are the complications that could arise, right? During this period. So let's say this patient returns 14 days now, right? Or 2 weeks later. And this patient is complaining of chest pain. So now they have new onset chest pain. And they said the chest pain is relieved when they lean forward. Right? So it sounds like the post-infarction fibrillary pericarditis that we saw earlier, but this is occurring after 2 weeks, right? So this is what we refer to as, so this is also a form of pericarditis, right? But this is going to be what we call Dressler syndrome. So clinically, the way we're going to differentiate Dressler syndrome from post-infarction fibrillary pericarditis is going to be the timing on the exam, so the timing. And what's Dressler syndrome? Basically, is a condition whereby our body is making antibody against those collagen, those fibrous tissue, because that's not what they are used to, right? That's not what's supposed to be there. So now it looks like a different tissue is being there now, and then because they don't recognize it very well, what happens when our body when we have any foreign stuff in our body, what happens? Our body looks for a way of fighting. So same thing. So the body start making antibody against it, and those antibodies create inflammation in those areas, and that causes what we call Dressler syndrome, right? Same thing. I dose also call them aspirin to treat Dressler syndrome. Other thing that will also occur during this period is that each time somebody has a heart attack, right, and we repair the muscle, right, that infarcted muscle, when we repair it, it's not being repaired by a real muscle. It's not going to be like a striated muscle that to be there. They are being repaired by just collagen, fibrous tissue, by scar, right? So each time somebody has a heart attack, they are losing their healthy muscle. They are losing those cardiac muscle. So as a result of that, it's going to get to a point whereby, and then those fibrous tissue, they can't, or those collagen, they cannot contract like a real cardiac muscle, right? So as a result of that, those people, they have to be losing their contractility, and as a result of that, they can develop what? They can develop heart failure, right? Which is usually mentioned as heart failure secondary to what we call chronic, maybe from chronic ischemic heart disease, right? So from ischemic heart disease. The next thing that will also occur after this day is that this patient can have what they call true ventricular aneurysm. So now, because those fibrous tissue, they are very soft, so what happens is that sometimes they can bulge out, right? So you can have something like this that bulge out. So they can bulge out like this, right? And they have to be communicating with inside of the chamber of the ventricle. So what happens as a result of that? So this, so now they can form like a true aneurysm, and with this true aneurysm, one thing you're going to see on the history to recognize this, like somebody will have a heart attack, like let's say 2 weeks ago, right? And you do a EKG on them, and they have this persistent ST elevation. So when you see that history on the exam, somebody will have heart attack 2 weeks ago, and they still have persistent ST elevation, right? If this is happening in the context of chest pain, like a new onset chest pain, this could be maybe with stenosis. So let's say you put in a stent there, this could be like a stent thrombosis. Yes. So somebody who is having maybe new persistent ST elevation or new ST elevation in the context of chest pain, right? An elevated cardiac enzyme, it may probably the stent that it was put in, now the stent is thrombosed. So that's something that we need to remember. But if it's like no chest pain, but they just have this persistent ST elevation, it could mean probably they form true ventricular aneurysm, right? And that's something we need to remember for the exam. And what's the issue with this ventricular aneurysm is that blood can pool in this area, and this area does not contract that much, right? So that means there ought to be increased risk of what? Mural thrombus. So mural thrombosis. And then this mural thrombus, right? can dislodge, right? So it can come out from there, right? Some of these can dislodge, right? And they come out and go into the brain, and it can lead to stroke. So if I see a question, somebody who had a heart attack, like maybe let's say a myocardial infarction, like 2 weeks ago or 3 weeks ago, now the patient is presenting with maybe one left-sided weakness, or they can't speak, and on EKG, I see persistent ST elevation from previous admission, then I know most likely this might be related to mural thrombus. So that patient might need echocardiogram to look for those mural thrombus. And what about if similar scenario, this same patient is now presenting with severe leg pain, and on examination, when I look at the leg is cyanotic, there's decreased pulse, I can't palpate the pulse on the leg, it's really painful, right? And we look at the EKG, there's persistent ST elevation. So that could mean perhaps the mural thrombus has gone to their leg, right? Leading to what we call critical limb ischemia. So these are just different scenarios that we should remember, that different way that they can ask us on the exam. And I hope this helps us to understand the process of that coagulative necrosis and how our body is able to deal with them, right? And in the next session, we're going to be talking about another type of necrosis, which is liquefative necrosis. And I thank you guys for watching. And please don't forget, like I mentioned, if you have not subscribed to this channel, you're really missing a lot. Don't forget to subscribe to this channel, support this community, be part of this community. And if you guys have any question, I'm going to leave my email address in the description box. Don't forget, you can always send me your questions. And if you have any particular topic that I don't think I understand, if you can please explain it to me, you can also send me an email. I will definitely make a video on it. I will go and read it. Even if I don't know about it, I'll go and read about it and make a video for you on it. Thank you guys, and I see you guys in the next video.